Hello everyone, welcome to the ATCM Emergency Medicine channel. So, as the COVID is coming back wave after wave, we are very much into the lookout for the existing therapies and the newer therapies which could make a difference. So, the current interest everyone has is to understand the Roche's cocktail, otherwise the Roche's monoclonal antibody cocktail. So there are so many facts, so many myths about the monoclonal antibody, about the cost of the monoclonal antibody, what is the real advantage of the monoclonal antibody, what is the target population we need to give. So in this brief communication, we will try to cover all those aspects so that you will get a clear view when to administer these drugs and whom to give this drug for, to get the maximum utility of the drug and to get the cost effective utility of the same. So coming to the Roche monoclonal antibody cocktail, it is known as a cocktail because it is a combination of two antibodies. One is the monoclonal antibody called Casirivimab and second is the monoclonal antibody called Imdevimab. So since both of these monoclonal antibody are targeting two different sites of the spike protein, since it's a combination of two antibody, it is known as a cocktail. It is produced by Roche and it is marketed by the Cipla in India. We all know that when Trump took the monoclonal antibody during the late 2020, it came into prominence. But in India, it got approved only recently. In June 2021, the CDSCO, the Central Drug Standards Control Organization of India, has approved the use emergency use authorization, given the emergency use authorization for this drug in June 2020. And so let's proceed with the description of the drug. So the trade name of the drug is Regeneron and it is marketed by Cipla. It is a combination of two monoclonal antibodies and it is an IgG antibody. The mechanism of action, as I already told, it is targeted against the spike protein. And what is the target group in which this monoclonal antibody can be administered? The target group is 12 years or more and the minimum body weight has to be 40 kg. So this is the prerequisite for administering the cocktail. So the dose of the monoclonal antibody is 600 mg plus 600 mg. The per vial, one monoclonal antibody, 1200 mg, there is 1200 mg of monoclonal antibody per vial. So one vial actually can be used for two patients. So there are advantages as well as disadvantages for this combination. The advantage being one vial can be used for two patients, so the per cost for per person will be 60,000 only. The disadvantage is that whenever we administer half of the drug to one patient, the other half has to be utilized within a period of 24 to 48 hours. So if we are not able to get another person within this short duration, then the first person has to bear all of the cost, including the 1.2 lakh. Coming to the route of administration, the route of administration is intravenous route as well as subcutaneous route. But the preferred route of administration is always the intravenous route. How to dilute the same? The dilution of the drug is in normal saline. It can be as small volume like 50 ml or 100 ml or 250 ml. But irrespective of that, it has to be infused over a period of 1 hour. At the end of the infusion, the patient has to be observed for the development of any adverse events for another hour. Can we give subcutaneous? Of course, subcutaneous is an alternative route for the patients who don't want to get IV drug or the patients who do not want to observe for more than an hour. So in this patient, we can give the antibody as 2.5 ml syringes at 4 different sites. So total it will be 10 ml, 2.5 ml each per syringe, and it has to be given in the outer aspect of the thigh, outer aspect of the arm and in the abdomen. It has to be 2 cm lateral to the umbilicus. That's the only point we need to remember while giving subcutaneous. But remember, the preferred route is always intravenous. Coming to the adverse reactions. So the infusion related adverse events are kind of described but is uncommon. Here in Amrita Hospital, we had given close to 20 patients and only one person had an adverse reaction to the at the time of infusion. Basically, it is an infusion related adverse reactions, and as we can anticipate, mostly it will be related to allergy and it will be like fever, chills, myalgia, headache, or the proper allergic manifestations like pruritus, urticaria, angioedema, throat irritation, bronchospasm. And sometimes if they are prone to anaphylaxis, then in the early phase they can get a dizziness as part of the hypotension, or even they can go into frank anaphylaxis. In the patient whom when we administer, only 1% developed allergic reaction, that particular person had a low BP as well as dizziness. We had given the IV medication, to which he has responded well, and there was no reason for the patient to get hospitalized. So the adverse reaction can happen, but kind of very less common. But this is important point to note, because that precludes any self-administration of the drug, and the patient should take the medication in a healthcare facility so that the observation period can be completed, and at the end of the observation period, after checking the vitals, ensuring the stability of the patient, then only we should discharge the patient. So that is something which we need to keep in mind. Coming to the storage and drug-drug interaction, there is no clear drug-drug interaction reported for the monoclonal antibodies. The serum half-life is roughly 30 days, and the storage of the unopened vials can be done in 2 to 8 degrees Celsius. Now the boiling question: whom should we administer this antibody cocktail? The antibody cocktail should be administered to patients who are classified as high-risk individuals. So who are the high-risk individuals? The patient who have comorbidities like diabetes, malignancy, on immunosuppression, on chemotherapy, pregnancy, then obese patients, patients who have other neurodegenerative disorders, patients who have underlying chronic lung disorders like COPD, severe asthma. So in this group of individuals, there is a high probability of them progressing to a severe disease in the eventuality of them developing a COVID-19 infection. So in this group of patients, we should definitely target to give monoclonal antibody, or otherwise we should give them the option about the possibility of a monoclonal antibody and prevention of progression to severe disease. So the other target group being non-vaccinated individuals. As we know that it is an antibody. When we vaccinate, it is like active immunization. So if a patient has not been vaccinated, then there is no antibody. So in that group of patients also monoclonal antibodies can be administered. Then when to administer this monoclonal antibody? The timing of, as we know, the target group whom we should administer the monoclonal antibody. Best time to administer the antibody is during the early period of the disease, within 3 days. Mild to moderate disease is in which the monoclonal antibody has been approved, and moderate disease means the saturation is more than 90 without oxygen, and if it is more than 95, it is mild disease. In patients who have low immunogenic response, in that group also, for example, transplant patients on immunosuppression, in that group also we can preferably give monoclonal antibodies to prevent the progression to severe disease. Now coming to the few frequently asked questions regarding the monoclonal antibody, so that we will get a much clearer understanding. As I told, it is early in the disease, preferably within the first 3 diseases, where the viral multiplication is at the maximum, the viral load is at the maximum, and as I told, it is a neutralization antibody which will neutralize the virus, and during the early period, this will be this viral multiplication being maximum. The maximum utility of the drug will be if we can administer the drug during the early part of the disease. In late part of the disease, we know that viral multiplication phase will be over by around a week's time, and afterwards it will be mainly immunologic phase which is causing all the hypoxia and related side effects. So during that time, if we are administering monoclonal antibody, it could even increase the immunologic response, and then it could lead on to deterioration of the disease as well. So definitely not in the later part of the disease. So this clarity we need to have. Up till 7 days is okay, but preferably within 3 days. Coming to the interaction with other vaccine. So whether being monoclonal antibody, whether it will interact with other vaccine. If I have taken the monoclonal antibody, when can I take the vaccine? So these are another questions which we frequently come across. So one thing, as I already told, the half-life is kind of very long. Within the T half is 30 days. So up till 90 days, the monoclonal antibody can be there in the system. So definitely we should advise them to avoid vaccination up till 90 days because there is a passive immunity, and this antibody can neutralize the adenovirus vector vaccine, which is the Covishield vaccine. So definitely if you are taking Covishield vaccine, better to wait for 90 days after you have taken the monoclonal antibody. So that is one thing we need to keep in mind. Even in case of mRNA vaccine, it is better to wait for a period of 90 days after the administration of the monoclonal antibody to take the vaccine. So as we know, in the pregnancy has been categorized as high risk group because especially with the advent of Delta and Delta plus variant, we are increasingly seeing more pregnant patients becoming hypoxemic and requiring hospitalization. So in pregnant patients, we can definitely tell them the possibility of monoclonal antibody and its potential to prevent the progression to severe disease. In breastfeeding mothers also, if they have other comorbidities, there is no contraindication to administration of monoclonal antibody. The major risk factors I have already told. One risk factors which I skipped include age of more than 65, obesity, and then the chronic kidney disease. So how the monoclonal antibody is being made? It is made in the laboratory by the spike antigen, expressing the spike antigen and showing it to the WBC. The WBC will in turn start producing the antibodies, which we will separate it out and will given us a antibody cocktail. So can it be cost effective? So that is one thing which we all want to know because it is like 60,000. It is not a small amount at all. So how can we tell a particular person to take an antibody worth 60,000? What is the cost effectiveness an individual is going to get? Because every individual, before taking the monoclonal antibody, they would want to get a clarity on this particular aspect. So that is why we need to clearly understand it is not for everyone. It is only for that high risk individual whom if we are not interfering, there is always a possibility and probability to progress to severe disease. So the high risk group which we already mentioned, like the immunosuppressed group, the malignancy group, the person who is on cancer chemotherapy. So in this group of patients, once they get the COVID, there is always a probability to progress to severe disease and getting hospitalized. So in this particular group, if we are giving monoclonal antibody, the progression will be prevented and hence the hospitalization cost definitely will not be limited to a 60,000 in case if they progress to a severe disease. So that is something which at an individual level a person has to consider before deciding on taking or refuting the monoclonal antibody, and that is where the cost effectiveness coming into the picture. So if you have a high risk medical condition, then definitely it is worth considering. And as we know, timing and type of the patient is the two important thing which we already discussed. So what is the difference in administering antibody compared to vaccination or plasma therapy? All these are various types of antibody mediated responses which we try to induce in a patient. So vaccination is basically like a active immunization where we inject antigen and the body will produce the antibody, and it is like a polyclonal antibody response which we are getting. Whereas in case of monoclonal antibody, it is like passive immunization where we administer the already formed antibodies to already made monoclonal antibodies to a particular person. So it comes to the next question, whether the vaccinated individuals who already might have a good polyclonal response whether there is any need for them to take monoclonal antibody. So definitely, if it is a healthy young adult where we are anticipating high level of polyclonal antibody response to the vaccine, then definitely there is no need for us to advise them about the need for monoclonal antibody. But whereas in conditions like immunosuppressed individuals, for example, recently in the publication, in JAMA publication, they have told in mRNA vaccine, otherwise mRNA vaccine has a monoclonal antibody response of 95 to 100%, whereas in post-transplant individuals, the antibody response is less than 50%. So in this particular group, definitely because the antibody response induced by the vaccination being very low, these people are definitely going to benefit by administration of monoclonal antibody. Otherwise, the passive immunization will have a role in this group of vaccinated individuals. So, we cannot recommend monoclonal antibody for all vaccinated individuals as a blanket therapy, but we can carefully choose those individuals who might not have developed adequate immune response to the vaccination. So, another question is, compared to other antivirals like remdesivir, what is the difference, or what is the big thing about monoclonal antibody? So other antivirals like remdesivir, mainly we will administer for hospitalized patient. The data is for the hospitalized patient, whereas in case of monoclonal antibody, it is mainly for the OP patient. It is to prevent the hospitalization. So it has more of a preventive ability compared to a therapeutic ability of other antivirals. Effectiveness of the same for COVID escape variant. So that is also a concern. So with new variants coming out, whether the monoclonal antibody will stood the test of time. So definitely the original monoclonal antibody has been developed against the original alpha variant, but now we have delta and delta plus variant. Still the monoclonal antibody has proven to be effective, but whether it will continue to be effective or not is a question which we need to answer, and that will happen. And I think we need to do more research as more and more variants comes out to see the effectiveness of the vaccine. At this point of time, we cannot tell anything more than that regarding the continued effectiveness of the monoclonal antibody. Coming to the trials and data. So mainly the trials has been done in 4 settings. One is the outpatient setting, second is in the inpatient setting, and third is in the prophylaxis, primary prophylaxis. Monoclonal antibody is a primary prophylaxis in nursing home patients who are at high risk for getting COVID-19, and another is a primary prophylaxis for other family members whose one family member turned out to be COVID positive. So these are the settings in which the monoclonal antibody trial has been done. So we will see few data related to the same. So this is the first data, which is first figure, which is showing the change of the SARS-CoV-2 viral load from the baseline with the passage of time. Here we can see, compared to the placebo, which is the blue line, the red line and the green line, which is the Regeneron, otherwise the monoclonal antibody group, they have had a higher reduction of the viral load from the compared to the baseline. So that indicates definitely the viral load reduction is happening at a faster rate, at a faster pace in case of monoclonal antibody. This is important because, as we know, in most of the patients who are progressing to the severe disease, they have a high viral load at the time of admission, and also they have a persistence of high viral load. So a drug which can reduce the viral load is definitely going to come handy. So this is one of the primary outcome, whether there is a antiviral activity and whether there is the viral neutralization effect of monoclonal antibody, which has been proven in this particular trial. Coming to the cumulative incidence of symptomatic COVID-19, this is in that prophylaxis group which I have told. The trial happened in the prophylactic group, that is the in the family in which one of the member being COVID positive, as well as in the nursing home group. So in this group we can see, with a passage of time, the blue line, which is the cumulative incidence of symptomatic COVID-19, is going up, whereas the red line, that is in the Regeneron group or the monoclonal antibody group, it is remaining stable. So there is a 76% risk reduction if we are giving monoclonal antibody for primary prophylaxis. So definitely there is like 3 to 4 times higher incidence of COVID positivity in patients who are categorized as high-risk primary contacts. The third figure, this is the most talked about figure. I think you all would have heard about this particular figure and particular number. That is, there is a risk reduction of 70% when we administer monoclonal antibody. When we understand this figure, we need to clearly remember the fact that this is not for not for all the patients, but this is a comparison of the monoclonal antibody versus placebo, in which the monoclonal antibody has been administered only to the high-risk population, which I have already told. So when we give monoclonal antibody to such high-risk group, the risk reduction which they have observed is 70%. That is, there is a 3 times increased hospitalization, even leading on to death in case of the placebo arm compared to the monoclonal antibody arm. That is what a 70% risk reduction in hospitalization bar mortality means. With these words, I am concluding the topic on monoclonal antibody. I guess from now onwards you will be able to clearly choose the target group for administering monoclonal antibody, thereby helping them preventing the progression of the disease. Thank you very much.